Enjoy it.
Yep.
Say hi to Dan for me.
I will. I will.
Hey, Marcos.
Yes, sir.
About the text I sent you today, we're having a little bit of conflict on that weekend date,
Okay.
so we might be trying to move it to the following weekend.
Okay.
But I got in touch with Steve Salinger and have texted Josiah and Steve Nagrati. So I'm waiting to hear back from them to see what they think about that.
Yeah, they'll be very, very important to getting the word out about all of it.
Yeah.
This Steven Salinger found that one place that we're going to be asking about because I don't know if they did certain rates for students or what, but they gave him a good price, and then we're gonna just call and ask about it again, just because I think it was like $200 or $300 for the whole day, and compared to other places that are way more expensive. So if that's an option, that'd be nice for you for sure, because then you only need the hotel instead of the hotel in the room.
You broke up a little bit there. How much was the asking price for it?
So they told us it was like $200 or $300 for the whole day, and but it's a different price on their website. So we're gonna call them and kind of get an idea of what the price is for, because we were students when we're saying we're students as well. So maybe they gave us that, but we're just gonna call tomorrow and see what their pricing looks like.
Okay, and then we'd only be doing a 4-hour seminar.
Yeah, so then it would be even cheaper, I'm assuming, if that was the price for the day.
Yeah, it'd be great if we could do that.
Yeah, I'll definitely try and check it out tomorrow, because they weren't available today, and I tried to call.
Okay, sounds good.
Yes, sir.
Hey, Dr. Wood. It's Daniel Shannon. How are you?
Hey, Dan, how you doing?
Doing well.
Where are you at these days?
I'm back where I grew up in the Southern California area, running a practice with Jessica.
Cool.
Yep. Keeping busy and following the plan, you know?
Good. It's good to have a plan.
Yeah. I meant, running Gonstead and doing it the right way. So.
Good. I'm glad to hear it. Keep it up.
Dr. Wood, what's up?
Hey, George.
It's nice to see your beautiful face.
Well, I don't know about that, but it's nice to see yours.
Happy New Year.
And to you as well. Hope you've had a good start to it.
Yeah, it's always good.
Do you want to start maybe 2 minutes, Dr. Wood? Just give everyone to
Okay.
get in here.
Looks like people are still joining in, so.
Yep. All right, Dr. I think people are just going to straggle on as the time goes on anyway. So if
Okay.
you want to get started, and then just let me know where you want me to start, or if you want to just talk, and I'll follow your lead. Alrighty?
Okay.
Thank you.
All right. Well, Happy New Year to everybody. Getting an early start on discussing some aspects here of the Gunstead work. So it's my privilege and pleasure to spend some time with you over the next hour or so, and hopefully we can share a little bit of information with you on the shoulder injuries that we've seen over time, and how we evaluate and manage those shoulder problems. So Marcos, why don't you go ahead and put up the outline? Okay, why don't you scroll down just a little bit there, Marcos? There you go. All right. So the case history. This is really where it all starts. If we have a patient come in with they complain of a shoulder problem, the case history is where we can determine where that patient's problem is actually at. Did you know there's at least 8 different areas or subluxations that can occur when a patient comes into the office and says, "Hey doc, I've got a shoulder pain." And if we don't examine and explore that statement quite a bit, then we're very likely to end up adjusting the wrong area. So the case history, whether we're dealing with an extremity problem or a spinal subluxation, the case history is really where it all starts. There's not very much emphasis placed on this by most people, but this is where Gunstead got all of his symptom vertebra or extremity vertebra symptom correlations that we learned from him over the years that helped us to pretty quickly determine which is which and what's what. So as I mentioned, we have 8 possibilities at least for pain in the shoulder area, depending on how the patient was injured and so forth. So usually every case history starts out with the the main question, which is concerns the patient's main complaint, their main purpose for being in your office that day. So you want to ask the patient why they're there in your office. You might make a comment as to, I see you wrote down here that you have shoulder pain. Why don't you tell me about that? And then let the patient talk for 1 or 2 minutes until you feel that they've completely described the problem to you. And then you can go to your question answers. So we want to define that problem as quickly as we can. And usually the case history, once you get down a consistent method of doing it, the case history should only take maybe 3, at the very most 5 minutes. So the Q&A is a big part of getting that time that you spend on the case history down to a manageable time. So questions, the PQRST evaluation, their questions are really the ones that settle that for you and get you a good idea at the end of that discussion of where the problem is at. Is it an extremity problem or is it a spinal subluxation? So during that question and answer, I always talk about in my seminars that we also do show and tell. And so it's not enough for us to ask the patient to point where the shoulder problem is at, because a lot of times they'll just take their hand and touch it up here. And well, that touches almost every joint that's possibly affected by the subluxation, whether it's extremity or vertebral. So we need to have them pinpoint. We want to say, if you could use one finger to pinpoint where the shoulder is hurting most, then that will help us a lot in determining what the problem is. So show and tell is very, very important. And then the next thing is for you to touch that same spot and make sure that the patient knows that you know exactly where the problem is. So that goes a long way in patient trust and for them to understand that you are, completely on purpose and trying to understand exactly what their problem is. So many times the patients complain of going into a doctor's office and really not getting their questions answered and didn't feel that the doctor knew where the problem was at. So let's eliminate that as a possible deterrent for them to return and make sure that we understand where the problem is at and that the patient knows that we know where it's at. All right, so let's go on to the possible scenarios of our case history findings. I'm going to have to bore you a little bit here with the possible scenarios that patients would come in with these different types of shoulder problems. And so let me just read a little bit of this to you here. So patient number 1. If the patient was hiking, they came into your office and they're doing your case history. The patient says that they were hiking on a mountain trail a few days ago, fell over a rock and landed on her shoulder, reporting pain at the front of the glenohumeral joint area, and that it radiates less than a few inches. There's edema at the front of the joint and is painfully sharp to palpate. The arm is in a sling, and the patient says she can't raise her arm up in front of her more than 45 degrees. So here we have a patient with one scenario. Key phrases here that we want to pay attention to in this scenario are the location of the pain, which is at the anterior of the glenohumeral joint, and that they can't raise the arm up in front of them. Okay, so those are 2 key factors for pinpointing an AI shoulder. Right? Number 2, our next patient comes in. So they were hiking on that same mountain trail, tripped over a large rock, and she fell forward, stretching out her hands to catch herself as she fell forward. On impact, and afterwards, she felt sharp pain at the posterior of her shoulder and reports that she can't raise her arm up laterally in abduction for more than 20 degrees. So the key points here are, again, the location of the pain at the posterior of the joint, or possibly at the top of the joint, and that she has limited abduction. And so this is a key, 2 key findings for our PS shoulder. Okay, and then we have our 3rd patient. They come in and complaining of walking on that same rocky mountain trail and tripped over that large rock, falling forward. She tumbled onto her shoulder, complains of sharp pain and a protrusion on top of her shoulder area. She says it's swollen and red and has affected most of her normal ranges of motion to some degree, especially raising her arm and abducting it. So this patient, typically we would find an AC acromioclavicular joint separation with this patient. Okay, so we have this protrusion of the distal head of the clavicle as subluxated superior on the AC joint. Goes superior, a little bit posterior. All right, patient number 4 comes in. They've been on that same mountain trail, stumbled over the rock, and complains of sharp pain and a large protrusion that feels like bone in her upper lateral pectoral area. Her arm has been almost totally useless since it happened, and she has it tied her arm to her side with an ACE bandage. Okay, so this patient has a dislocated shoulder. The head of the humerus has slipped out of the cuff and has slipped into the upper pectoral area. So upon examination, we'll talk about that a little later, but on examination, we're going to find the humeral head sticking out of that upper lateral pectoral area. Okay, so our 5th patient, doing that same mountain trail, tripped over the rock, tumbled forward onto the shoulder, and complains of sharp pain and protrusion of what seems to be a bone near her sternum. All right, so here we have a sternoclavicular subluxation, where the proximal head of the clavicle has subluxated a little bit superior and anterior, and so this requires a different method for correction. So again, the location, the patient pinpointing and you visualizing that and confirming it by touching it yourself. Number 6, the same patient walking that mountain trail, falls over the rock, complains of sharp pain and protrusion in the center of the collarbone. Okay, and then here we see it's swollen, inflamed, very painful. And here we have a fracture of the shaft, the mid-shaft area of the clavicular bone. All right, and then we have our 7th and 8th patients here. Our 7th one has walking that same mountain trail and complains of sharp pain after falling on it on her shoulder. Sharp pain at the front of her shoulder. Has difficulty raising the arm forward. However, she reports that she's been having problems with that shoulder on and off for the last 4 months. Okay, she says the pain starts at the top of the shoulder blade on that side, and she feels pain that radiates down the posterior of her upper arm, down into the inside or ulnar side of her forearm. And so this patient likely has a combination of both a vertebral and an extremity subluxation. So again, the location of the symptoms, the fact that it's radiating is a big factor, helping us to understand that this is more than likely, if not solely a vertebral subluxation, but in this case also a combination extremity and vertebral subluxation. And finally, number 8, we may have the female patient who complains of anterior shoulder pain that radiates down the upper arm and her lower radius and into the thumb and index finger. And she's had a problem for 2 months and didn't have any injury at the onset of the pain. However, she did report she was in a car accident 4 months earlier, in which she was hit from behind. So this is likely, again, we look at the location of the complaint, and as she describes it, we ask questions about it, we find out that the pain is radiating down into the arm. So this is almost always a giveaway that we have a spinal subluxation. Most extremity injuries, the pain is going to stay fairly localized. It doesn't usually radiate. Can it? Yes. But usually it's going to be localized within a couple inches, 2 to 4 inches of the joint involved. Okay, so we see here that we have to ask the right questions. We have to do our show and tell, and we have to have the patient participate in demonstrating exactly where the problem is at. And by doing so, we can then determine fairly quickly from our case history where the problem is at, and then we can move on to our second step, which is our analysis. Okay, so as you look at the screen there, we have the chiropractic analysis that confirms or rules out our suspicions as to whether we have a spinal or extremity or both. So we just use our Gonstead evaluation process, and that involves our static palpation. So what do we look for when we do our static palpation on our patients? And with that, we typically feel along the anterior and posterior of the glenohumeral surface. At the anterior, there's maybe a 1/4 inch space from the upper aspect of the joint down to the pectoral attachment there. So we're going to evaluate that space for any adhesions that may be present, little fibrotic areas that are little lumpy, bumpy protrusions that might be present there. Especially we'll see these when patients have had problems for a number of months or a number of years. So we look for that with our static, and we, excuse me, we also look for edema along the joint in that area. Again, at the anterior of the joint, and for any redness that might be present there as well. And also keep your eye on the patient's face as you palpate, because when they experience pain, they're usually going to demonstrate that with a change in their facial expression. So keep an eye on that as we do our static and motion palpation. All right, and then with our motion, our typical way of doing the motion is really just to have the patient's arm hanging at the side. We'll show that on the video here shortly, but have the patient arm hanging to the patient's side, and then reach down with the doctor's hand on the side of the patient's complaint, and then pick that arm up. We're going to do kind of a circumduction type motion. And as we raise the arm up, we're going to turn the palm up. And then as we get to the top of the motion, we're going to turn the palm down as we go down. And so as we do that circumduction motion, raising the palm up as we go up, turning the palm down as we go back and downward, we want to be feeling the head of the humerus for normal motion in that joint. Is it clicking and popping? Is there any crepitus in the joint as we do that? And those can all help us to determine what's going on with that joint. This is typically a motion that we'll do when we check for an AI subluxation, where the head of the humerus is dropped anterior and inferior, AI. The patient with a posterior superior shoulder is going to have difficulty raising that arm in abduction. They might be able to raise the arm up in front of them in full extension. They might be able to move the arm straight backward, but they just have difficulty abducting that arm because the head of the humerus has gone posterior and superior. Okay, and so in our visualization, again, we're looking at any redness, inflammation along the joint, or any edema that might be present there. Now, of course, the delta T or the nervoscope is instruments that we'd use on the spine to help us to determine if we have a subluxation in the neck or upper thoracic area that may be contributing to that patient's complaint. Okay, then our fifth thing that we want to do with our analysis is our X-ray. So if we determine that we have an extremity subluxation, you want to X-ray that joint, and not only the painful one, but the normal one as well. Seems like extremities oftentimes have, if there's a malformation present, they're oftentimes present in both extremity joints. So it's good to X-ray both of the joints, both hands, both feet, both shoulders, both knees, so that you can compare one to the other and not mistake an anomaly for a subluxation. And this is especially helpful in the ankle and wrist, where we have so many bones that are present there and overlap one another. It'll just help you to pick out whether or not you for sure have a misalignment or side slip of a bone rather than just an anomaly. So X-ray every extremity that you're going to work on. So in the shoulder, depending on how you take the film, you should see a joint space in there of about 1/4 of an inch between the glenoid fossa cavity there and the head of the humerus. You also want to examine the joint, the X-ray, for any spurs or degeneration of the bone along the cortex of the bone, either in the glenoid or on the head of the humerus. Also examine the neck of the humerus for any trauma that may have occurred there. So look at the location of that femoral head. If you have a dislocation with the head of that humerus out of the socket and in the upper pectoral area, you'll surely want to know that. Look at the AC joint. If you have an AC joint separation, you will likely have a distal clavicular head that will be elevated above the acromion. So look for any separation there. Look at the sternoclavicular joint if the patient's complaining of pain at the sternal joint there. And you don't always see a lot of misalignment there unless there's just a real severe injury to it. But nonetheless, you want to look there. Look at the clavicular shaft to see whether there's been a fracture along that shaft. There may be just a radiating fracture line rather than a complete fracture separation of the shaft. Sometimes they will fracture and overlap one another. And so sometimes those need to be surgically repaired if they've determined that there's been a interference with the blood flow or nerve supply there. Those may have to be corrected surgically. So those we typically refer out to have somebody else take a look at it to make sure they've got a good nerve and circulatory supply there. Okay, the next, don't go too far there, Marcos. Next thing would be analyzing the lateral and the A to P films for open disc spaces or tilting or scolioses that may develop that may be the cause of the spinal related shoulder symptoms. So what do we do with our, when we look at an x-ray, a spinal x-ray, to determine if we have a shoulder problem from a spinal x-ray? And so on the lateral, the first thing we look at is whether or not we have disc spaces that are open to the posterior. So this is important because this oftentimes indicates that when we have a disc that's open at the posterior, indicates that that's the compensatory misalignment to the subluxation below it. Now, sometimes we might have 2 or 3 or 4 vertebrae in a row where the disc spaces are all open to the posterior. And so whenever we see that in the cervicals and the upper thoracic area, then we're going to go down to the lowest one and adjust the vertebra below it. When we get into that transitional area from T3, T4, T5 area, when we see discs that are open to the posterior, then most of the time we're going to go down. If we have 2 or 3 in a row at that level, we'll go down to the bottom one and then adjust the one above, the vertebra above, or in other words, the last vertebra that's open to the posterior. Okay, so then once we determine that on the lateral, then we want to go to our A to P film. And we're going to look at that level. If we pick T3 from our lateral film, we go to the A to P and we look for any tilting of T3 at forming a new scoliosis beginning at that T3 level. Now, sometimes on the lateral, we might find T3 involved, and then we go to the A to P and the tilting occurs at the T4 level. And so this is where our instrumentation comes into play, and the instrument will tell us for sure which one needs to be worked on. So we want to make sure that we follow our scope. The instrument is so important. It'll find 99.9% of your subluxations in your patient's spine. So we need to spend a lot of time learning how to use that instrument. You need to practice it as soon as you can possibly buy one. Get a hold of it and start using it. It's going to take you a while. It's going to take a year and a half maybe to feel real comfortable with it. But if you follow the rules of how to use the instrument and do not commit the breaking of the rules, then your learning curve gets much shorter. But you can't just grab an instrument and start scoping people and not study how to use it and expect to become proficient at its use. It takes a long time. It takes a while. I got my first instrument when I was in 3rd quarter. And by the time I was in 7th quarter in clinic, I was starting to feel pretty good about using it on students. Another quarter later, when I started taking care of outpatients, then I was starting to feel pretty confident about it. So get a hold of it, start using it, practice with it whenever you possibly can. kids, adults, teens, everybody. Try to use that instrument as much as possible. Okay, so the last thing is I'm often asked about is surgical clips in the spine or rods. I don't know how many scores and scores, hundreds of patients that come in over the years with surgeries that have failed, and they have the surgical clips in their neck. They've had 2 or 3 surgeries on the neck, or 2 or 3 or 4 surgeries on the low back, and they just need an adjustment. They need some chiropractic care from chiropractors who have the understanding of how to approach a patient with these post-surgical failures. So we talk a lot about that in our seminars about caring for these surgical patients. The bottom line is wherever the instrument reading is, and you're confident with your instrument reading, then that's the vertebra to work on. Most of the time, surgeons fuse the compensatory vertebra. So that means usually they fuse the vertebra above the subluxation. And that's why the patients keep coming back. They come back in 6 months or a year after the surgery, complaining of the same symptoms. So the surgeon gets in there and he fuses, the next one below it. And that doesn't work, and so he goes down and fuses the next one. And so sometimes they get relief with that lasts for more than a year or so. But the adjustment is what they really need to correct the subluxation. So don't shy away from these patients with surgical clips or these rods. They can be adjusted. If you think about it, these surgical devices are implanted with screws that are about 3/4 to 1.5 inches long, depending on where in the neck or low back that they're operating on. And so how are you going to cause damage to those surgical clips or rods when you're only moving the bone a millimeter? So just learn how to take care of them. Find the subluxation with your nervous scope. And most of the time, you can adjust these very easily. They want to go back into place. You adjust them with a very minimal amount of pressure in most cases, and they adjust very, very easily. So get after them. I know a lot of you are saying, well, Dr. Wood, you can take care of all my surgical patients. And it's the same thing I said when Dr. Gonstead first started talking about adjusting fractures and so forth. I'd refer them all up to him. But we can't do that. We have to learn how to take care of them, and they will be thankful to you for it. Okay, our conclusions from our analyses. Okay, so if we have an AI, an anterior inferior glenohumeral subluxation, then we're in our analysis, we're going to find edema, adhesions, tenderness at the anterior of the joint there, and the patient usually complains that they can't lift up the arm. If it's a PS, posterior superior subluxation of the glenohumeral joint, we get that same edema, adhesions, tenderness, but this time it's at the posterior or at the top of the joint. And the patient can't abduct the arm. If it's an AC subluxation, the patient will demonstrate edema, complain of pain and prominence of the distal head of the clavicle that's moved superior a little bit posterior at the AC joint. If we have a fracture, then of course we're going to have edema, pain, prominence of the clavicular shaft somewhere along that shaft area, mid-shaft. If we have a sternoclavicular subluxation, then we're going to have that edema and inflammation, pain, redness at the sternal junction there. And that one has slipped, usually, as I mentioned earlier, it's gone anterior and superior. All right, and then if we have a spinal subluxation, we're going to leave the shoulder joint alone because the adjustment of the spine will correct this particular patient's shoulder area complaint. Years ago, I was going to a seminar out in Washington, in Seattle, with Dr. Gonstead. And on the way out, we got stuck in the airport. There was a big thunderstorm in Denver and knocked out all the electricity. And so we had to, I mean, there were tens of thousands of people in that terminal. And this was before they had the big one that they have now. And so we ended up sitting on the floor for several hours. And by the time I got to Seattle, I was having wrist pain. And it was just like carpal tunnel pain, top of my wrist. And I had a couple doctors look at it. 2 different doctors looked at it and adjusted the wrist itself, and didn't get any relief from either one of them. And then I had another friend check it on the next day of the seminar, and he found a T4 subluxation, and he adjusted that one time, and woke up the next morning with absolutely no pain. So don't ignore the spine as the cause for a lot of these extremity problems. You want to make sure that you have a subluxation in the extremity before you adjust it. Don't adjust non-symptomatic extremities. Make sure that they have subluxation findings before you start working on them. Because a lot of times you can start joint irritations that will take some time to clear up once you leave them alone if they're not subluxated. Okay, and then always review the films that you're going to have on the patient. Now, if the patient already had some films taken at a hospital or an imaging center, then you'll want to get a hold of those films and look at them yourself. Don't just go by the report. Years ago, I had a patient that was in a car accident, went into the hospital, and they treated him for all the injuries he had, and he especially had pain in the shoulder joint, glenohumeral area, and they put him in a sling and told him he just had a severe sprain to the joint, and sent him home. Came into my office the next day, and he was still complaining of the same pain. And I took an x-ray of it and found that the neck and head, there was a fracture at the neck and head junction of the humeral bone. It had slipped an eighth of an inch from where it should have been. And they missed that in their radiology department the evening before. So had I gone ahead and adjusted that as an AI shoulder, I could have been in a lot of trouble. So make sure that you review the x-rays. If you're not going to take them, they've been taken somewhere else, make sure you get a hold of them digitally. You can do that pretty easily nowadays. We used to have to wait a week to get the films by mail. So always look at the x-rays before you adjust the patient, not just the report. All right, so we move on to our points 3 and 4, which are our pinpoint and establish. We've determined from our analysis and our case history which joint is involved, whether it's an extremity or spinal or combination problem. We know what the listing is, whether it's an extremity or a spinal subluxation again. And if it is a spinal subluxation, you also know that whether we have a sympathetic or parasympathetic problem. Do the symptoms appear more to the radial side and thumb and finger area, which would tend to indicate more of a upper cervical, an atlas or axis subluxation? Or is the problem more toward the posterior of the shoulder, ulnar side of the forearm down into the fourth and fifth finger, which would be more of a T1 or T2 to T4 or 5 subluxation? Okay, and then our step 4 of the Gonstead approach to the problem is to decide our priority of adjustments. So is it an extremity subluxation? Is it a spinal subluxation, or are both involved? And so do we work on one or the other, or do we work on both? And so by following what Dr. Gonstead called his Gonstead approach, the 4-step process of the Gonstead approach, we can quickly come to an understanding of what that patient's problem is and what we need to get it corrected. All right, so we have some management questions or comments about the shoulder pain patient. Students often ask during the seminars, what's the frequency of care as a patient progresses? So that's always a hard question to answer because patients respond at different frequencies, different speeds. Some patients heal quickly, others don't. So there's no standard answer I can give you. But I always followed Gonstead's lead on caring for patients. Whenever patients started telling me that they were starting to feel better, I started to see them less and less frequent. So if I was seeing them 3 times a week for 2 weeks, and they were reporting steady progress during those 2 weeks, then probably I would drop them to twice a week for 2 weeks. And if they were doing well at the end of those 2 weeks, then maybe once a week for 2 weeks. Or if they were totally done with the problem, I'd discharge them. So it's going to vary depending on your patient and what kind of injury that they've had. How much trauma have they had? So just you have to take all of the information into account and decide whether you are going to treat a patient on a standard amount of care, no matter what, no matter if they progress quickly or slowly, or are you going to start to decrease frequency as the patients get better? And so that's what you need to determine from your own evaluation of your individual patient as to what their spines look like, what kind of damage did they suffer to the extremity if it's there, if that's where the subluxation is. And just use all of your evaluation steps to determine how your patient is progressing and what you think. When it boils down to it, it's what you think that patient is going to, or how that patient is going to respond, or how quickly. I wish it was an easier question to answer. I'd give you, so many adjustments, but it's not. It's just one of those things that you have to make a decision on. First of all, how are you going to treat your patients? Are you going to recommend a certain number of visits or months of care, no matter what, or are you going to work on more of a pain factor? Okay. So another thing would be number 2 here is to document your progress, especially with your car accident and work comp injuries. I think nowadays most insurance companies, if care goes past a month, they want a monthly report of progress. Some may want it sooner. You have to determine that with whatever insurance company you have that's involved. So the insurance companies are different. Some want to report every 5 visits or 6 visits. Others want once a month. So you have to figure that out when you join the different networks if you're going to make sure that you're aware of what they'll cover and what they won't. Because if you go past their guidelines, then they won't pay you for that care. Okay, so make sure you document your patient's progress. So ranges of motion are real good there. The pain scale are good there for patients to give you a regular indication of what their pain scale is. So acute sprain injury cases, anytime tissue is torn beyond just a minimal amount of damage, it's going to take at least 6 to 12 weeks for that tissue to heal, and maybe longer, depending on how much tissue has been damaged. So a little bit of a guide would be that for acute sprain injury where they've actually torn the tissue. Then you look at that 6 to 12 week range. If it's more of chronic degenerative extremity injury, it may take longer. You may be seeing that patient for 3 or 4 months before the problem is totally corrected. But on the other hand, sometimes these degenerative cases respond much quicker than an acute sprain injury. So again, be aware, ask the questions, and when they start getting better, especially the degenerative cases, make sure you start backing off your care, because you can certainly irritate conditions where there's a lot of calcium in a joint. All right, next thing would be ice. We always recommended patients use ice on their spine or extremity for 30 minutes each time they do it, 3 to 4 times a day. A lot of times we'd recommend home exercises for that particular joint, for them to do. A lot of stretch bands are a real easy thing for like shoulder, wrist injuries or leg injuries. They can buy those at Walmart and do those exercises at home. Then we often get a question on non-responsive patients. We have to be careful with those patients. Typically, when we adjust a patient and we get a good set, whether it's in the extremity or the spine, if we get a few good sets, 3 or 4 at least good sets, and they're still not getting better, then we're probably on the wrong bone. So with good adjustments, 1 to 4 or 3, 4 visits, there should be some changes beginning to occur. If you're not, then you need to really go back and start at step 1 and reevaluate your patient. Talk to them again, make sure that you're both aware of where the problem's at, and then go through your analysis process again and make sure you find the right bone. If you are in the right bone after 3 or 4 visits and the patient is expressing progress, then stick with it. If they're not, then, like I say, go back to step 1. Do that Gunstead approach again and make sure you find the problem. It's usually not very helpful to jump around. When patients don't respond as quickly as we would like, We have a tendency to think, well, that's no good. Let's go to this bone, or let's go to that bone, or this change how we adjust an extremity. A lot of times that's the worst thing we can do. So talk to your patient about what you're doing. If something's not working, I'd say, well, let's go back and talk about this problem again, and let's reevaluate it. And is this exactly where the problem is at? And have them touch it, and you touch it. Go through that whole process again, and tell them that, okay, maybe you found something different that may help, and you want to adjust this 2 or 3 times to see if we get a change in our progress. And so show them or tell them your options that you have here and how you want to eliminate them one by one, and then they'll stick with you. But if they're just not getting better for the 5 or 6, 7 visits, it's unlikely they're going to come back. So talk to them about their needs. Talk to them about what you're finding, how you're approaching the problem. You want to fix one problem at a time, and make sure that you're not over adjusting. And usually your patients will respond pretty well by following that process. Okay. So are there any questions about the shoulder process, the evaluation?
Dr. Wood,
Yeah.
what does clicking at a particular part of the shoulder joint tell you? Does that tell you anything specific, or are you more interested in the pain and edema?
What is clicking?
Yeah, like if it continuously clicks, like overhead throwing athletes all the time.
Yeah.
Yeah.
A lot of times you'll never get rid of that. Like you being in baseball, throwing that ball so hard all the time, you can have a clicking in that shoulder crepitus that's just never going to clear up. It may go away for a short period of time, but always comes back. A lot of times that's just due to the chronic injury of the joint.
Mm-hmm.
When tissue is destroyed, cartilage, it's just not going to grow back.
Mm-hmm.
And so when we have joints that click or pop like that, it's usually because there's either just the misalignment if it's more of an acute case, or in a chronic case, it's more of a wear and tear that's a permanent factor from that point on. And you can get it better. You can get it feeling better. You can get the pain out of there most of the time. And depending on the patient, it might be for months at a time. And, another patient comes in with the same problem, same clicking, and they only feel good for a week. So there's no way we can tell who's going to respond the best or the longest. But that's usually what we find.
Thank you.
Hey, Doc, I have a question. In terms of, and I've noticed with a couple patients, especially if they've been involved in sports, the bicipital tendon basically migrating out of the bicipital groove, maybe it's stretching the tendon that crosses over there. Do you have any recommendations for treatment with that, other than just pushing it back in and hoping it stays?
Yeah. I haven't worked on a lot of bicipital tendons, Dan. You can push it over, but again, if it's come out of the joint, why has it come out of the groove? And so if the tissue that's supposed to hold it in place is missing, was damaged or degenerated, then it's not going to hold that very well. And again, the people that are in sports for long periods of time and consistently irritate those joints, they're gonna have a persistent problem.
Sure, understandable. Just wasn't sure if there was something I could do to make it last a little longer. But yeah, I'm working on the spine and the shoulder, making sure it's stable. But just looking for that little extra edge, you know.
Yep.
Okay.
That'd be like asking Marcos to quit throwing a baseball.
Just doesn't happen.
Yeah. So patients are mostly unwilling to change what they like to do. And so, I just tell them, I say, well, if you don't want to quit doing that, I'm happy for you to come in and pay me $45 a visit for me to take care of that for you. I don't know how many times I've told a patient that. And they say, okay, but I'm not going to stop doing it, they'll say. I say, yeah, that's fine. I'm happy to take care of you.
Hey, Dr. Wood, I actually have a question as well.
Yes.
I know when you were talking about looking at the lateral film, I can't remember what you said about when you're looking at the thoracics. For example, when you were mentioning the cervicals, you said, look at the one below the one that's open at the posterior, and adjust that one. I can't remember what you said for the thoracics, though.
Yeah, the general rule Gunstead gave us was whenever we have disc spaces that are open at the posterior from C2 down to T1 and possibly T2, we're going to go down to the lowest one and then adjust the vertebra below that last open disc. Okay. And the reason we do that is because we're dealing with a lordotic area. But when we get into the thoracics, we're starting to get into a kyphosis. And so when the disc spaces are open to the posterior in the upper thoracic area like that, then we go to the, again, if we have 2 or 3 in a row, we go down to the bottom one. Let's say that, just to make sure we're talking about the same one, let's say we have T3, 4, and 5 are all open to the posterior. And so we go down to T5 because it's the last one that's open, and we adjust the vertebra above that open disc, which would be T5. Okay?
Got it. Thank you.
All right. And then for the lumbar lordosis, whenever we have an open disc space to the posterior at T12, possibly 11, down to L5S1, then we're going to go to the lowest one and adjust the bone below it, just like we did in the cervicals. Again, because it's a lordosis that we're dealing with. Okay.
Dr. Wood, do you want me to pull that video up?
Oh, yes. Yeah. Sorry, I was going to show that video a little bit after we did the analysis, but all right. So this is my grandson. I believe I had that curly, bushy hair at one time. All righty. So here, the video's not, or excuse me, the audio is not working here. So I'm just going to talk you through the process here that we go through on evaluating the patient for a glenohumeral shoulder injury, or an AC or sternocleidomastoid or sternoclavicular. So here we're doing an anterior shoulder. We want to palpate along that anterior joint. There's about a 1/4 inch space there. Runs for probably about 2 1/4, 2.5 inches down, depending on how big your patient is, all the way down to the tip where I'm touching there, where the axilla starts. And you'll find crepitus along there. You'll find adhesions along there, and tenderness. Patient will respond to any pressure on those points in there as well. And that's a sure sign that you have an AI shoulder. And so here the patient has trouble raising the arm up in front of them. Right? And then the next problem, when we adjust this shoulder, we circumduct the arm like this and feel for the movement in there. And here I'm just going right to the setup for the AI shoulder. Okay, and you firmly put your chest against the suprascapular area there of the patient. And then as you pull up with your contact hand, you turn the elbow slightly outward. All right, and then the next thing we'll discuss in here is the posterior shoulder. So here we might find pain right at the top of the joint or down the posterior aspect of the joint. For some reason, we don't find as much of the adhesions, the little fibrotic nodules that we find at the anterior. I don't know why, but in my experience, and maybe it's just because we don't have as many PS shoulders as we do AIs, but typically the pain will be in that back area, posterior area of the joint, and the patient has difficulty abducting the arm. Okay, so when we prepare to adjust this patient, we want to hold the arm. We're going to stretch that arm out as far as we can. Now, a lot of patients can't get their arm up this high, but whatever degree of elevation they can get in abduction, that's where we do this adjustment from. If you have a patient with a frozen shoulder, this is a typical PS shoulder, and they may not have more than 10 degrees of motion. So there's no way you're ever going to get it up this high to adjust it. So you have to adjust it in this manner from that 10-degree range of motion position. Okay, the next shoulder injury here that we're discussing is the AC joint separation. We can visualize this distal clavicular head is elevated, and there's typically redness and edema around that joint surface. And of course, the patient is complaining of pain in that area as well. So just pretty easy to determine this is an AC shoulder subluxation. Now here we typically will use our thenar on this, adjusting this joint. But we can use either the pisiform as well. It's just that when we use the pisiform, we tend to contact the acromion along with the clavicle. And so with the thenar contact, we have just more of a specific contact right on the distal head of the clavicle, and we can avoid contacting the acromion. So we elevate the arm, hold the arm at a 90 degree like that, and get almost straight up and down with our contact arm. It's going to be slightly posterior to anterior, but mostly superior to inferior as we correct it. Okay, we want to, if we're doing this in the seated position, we have the strap over the opposite shoulder of the patient, or have our assistant come in to hold that shoulder down. All right, and then we talking here about the manubrial clavicular articulation. Again, on visualization, you'll see a prominence of the proximal head of the clavicle, and there'll be edema around there. It'll be red from inflammation and from the patient rubbing it. It's very painful subluxation. This can be adjusted either seated or supine, just as can the AC separation. Okay, so with this subluxation, we're going to contact this with our thenar, and we're going to place it at the top and lateral border, and we're going to favor standing the opposite side behind the patient, stabilize the opposite shoulder, and then the thrust is going to be A to P, superior to inferior, and a little bit of a torque to that subluxation as well. And for this particular one, it would be a counterclockwise torque. And again, this can be done either supine or seated. Okay, and then if we have a fracture of the shaft, that's going to be pretty obvious. It'll be sticking up depending on what type of fracture. If it's an overlapping fracture, there's no question. If it's only a crack along the shaft of the clavicle, then that may only be visible by X-ray. There may be no outer indications other than severe pain that the patient has at that point of the crack. So again, X-ray the patient and look for any fracture along the shaft. Okay, I think that is all we covered on that. I'm not exactly sure what I'm talking about there at the end, but that's how we would evaluate those for different subluxations to the extremities.
Dr. Wood,
Yes.
how do you know if someone doesn't just have like just a different sternoclavicular joint on one side compared to the other, if they have some malformation to it compared to if it's actually, is it just very pinpoint in that one spot?
Yeah, they're going to have symptoms with it, and that's why, of course, we'd look at both articulations. We take pictures of both extremity joints that we're going to work on. So a lot of times they're bilateral in their malformations, and so we'll see those bilateral changes and know that it's not a subluxation. It's just an anomaly.
Okay, thank you.
Yep.
Hey, Doc.
Yes.
Got a question. When it comes to kind of older patients that have kind of a degenerative glenohumeral joint, that complain of kind of have a lot of crepitus in the joint when you move it, and kind of hyper painful during the range of motions. I found that some of the AI shoulders that I've adjusted can cause a lot of pain for that particular patient. Now, when it comes down to it, they get a little bit of range of motion back, but it's almost to the point where they don't want to do it again, even though that may be what need. Any suggestions on how to care for those kind of acute cases? Thanks.
Yeah, you have to really slow down on your adjustments. And you just have to talk to them. Look, I know we wanted to see you 3 times a week, but it seems like the adjustment is irritating it somewhat as well as helping in other ways. So let's just adjust this less frequently. Instead of coming in 3 times this week, just come in once.
Yeah. I found that I tried that with one of the patients, and it seemed that even just the one time or once a week, it was it aggravated a lot, especially because the patient was about 70.
Yeah.
But the degenerative crepitus was a lot. So do you suggest maybe even more focus on some range of motion before we even try to get to adjusting it afterwards to avoid irritating it?
Well, I would decrease the frequency like you did to once a week. But in addition, I mean, the discussion that you have is that it isn't going to make the adjustment not painful. It's just going to decrease the amount of irritation that you get from having 2 or 3 adjustments. So they'll still get the pain, but exercising like the stretch bands are good for them to start doing those right away, because you'll find that they'll be able to get adjusted after a while without having the pain if they're doing regular exercises at home.
When you refer to stretch bands, what motion are you specifically talking about?
Whatever motion that they can't do, you want them to go as far into that range of motion as they can without hurting it. But there's that physiological red zone, I think they call it, where that overlapping benefit that you get from exercising other joints around it that will benefit the joint that's injured. And so when I have patients like that, then I'll have them stand up here. I'll have them do motions with the arm like this, okay? And then out, away from their body. We'll have them, maybe they can go down and back, okay, but they just can't go up very far. So you exercise it as much as you can on different joints, get other muscles and joints involved, and you'll get that overlapping red zone benefit that will help decrease the irritation they get from the adjustments.
Perfect. Thanks, Doc. That was really helpful. Good
Yeah.
to hear from you again.
Where are you at, Anthony?
Vancouver,
Vancouver, that's right.
Vancouver, Canada.
Congratulations on your marriage.
Thank you. Thank you.
Any other throwing questions?
I have one regarding just frozen shoulder in general.
Frozen shoulder?
Yeah. So in your experience, is frozen shoulder usually like a spinal subluxation issue? Because I've heard that quite a bit. Or have you actually correlated someone who's come in with a frozen shoulder to an actual, shoulder issue or subluxation?
Yeah, sometimes there's an atlas involvement with a frozen shoulder. Most patients that come in, you're treating some spinal problems in addition to the frozen shoulder, because they usually have an upper thoracic area problem as well. But if you approach your analysis the way we've discussed, then you found a problem in both the atlas and an upper thoracic area, I would go with the atlas first for a while. And then if that didn't benefit, then I'd go down to the upper thoracic. But you don't expect to be in a hurry on frozen shoulders, PS shoulders. They do not respond real quickly, like an AI shoulder patient does. They're totally different. Why they take so long, I do not know, except for a lot of PS frozen shoulder patients have a lot of degeneration in their shoulder joints. So that's the main reason for those, for frozen shoulders, frozen degenerated shoulders. That's why they don't respond very quickly. But others where they don't have the degeneration, they still don't respond very quickly, like an AI does. So you're looking at usually at least a month, upwards of 6 to 8 weeks on these frozen shoulder cases. And some take even longer. So, but most AIs, you're getting good sets on it, 2, 3, 4 adjustments. They're doing a lot better. You need to leave it alone, let it heal. They adjust them periodically after that, and they'll do real well within a month. But PS shoulders, they're totally different. They're pain. You might not have any progress for a couple of weeks. Any. And so you just have to be confident in knowing what you're doing, and reassure the patient, give them the time schedule that you're looking for, and if you meet that time schedule and they're doing a little better, that's great. If they're not, then time to stop and reevaluate and talk again about what you want to do. But they have to participate. These PS shoulder patients, they have to participate in their own healing. ice, exercise at home, and get the adjustments.
With the PS shoulders, do you find that they cavitate as much as the AIs?
No.
Yeah, I haven't found any of my PS shoulder cases. I haven't found they cavitate almost at all. But there is marked improvement afterwards. Like you said, slowly, very, very slowly.
Yep, I would say most of the time you get your cavitations, maybe not on the first or second visit, maybe on the second, third, or fourth visit, and then not much after that. But yet they get better with each adjustment.
Hi. Question about not so much the shoulder, but what you were saying as far as missing, like the other doctor's missing the fracture in the atlas and occiput from the one case you had. I recently had someone come in. We took X-rays. Pretty sure we found a fracture at her T11, like of the vertebra. It, like looked pretty clear to us, so we sent her to the emergency room. They came back, did a CT, said no fracture there. Then she got an MRI. They said no fracture, but to us, it just looks so much like a fracture. So like how much, I guess a twofold question, like at what point do you know that you're definitely seeing it versus not seeing it? And then it's kind of, if we think we're seeing it, should we still adjust?
Okay, so what are you seeing is my question.
It looks like a pretty clear fracture. If you're looking from, she had her left side up against the bucky. We took it from both sides, but it looks like under the pedicles, almost straight anterior to posterior across the vertebra, like not straight, but a little angled. But that's why we sent her to the ER. But
You're seeing a fracture line, a white line or a dark line, or?
Yeah, like white line fracture. And she did have a fall. She fell like forward on her chest. She thought it was ribs, but 2 weeks later still wasn't getting any better. And she was the wife of a patient, so we had never actually seen her until we did the exam and saw that fracture. So she hadn't been adjusted before.
Well, is it a white line?
I believe so. Yeah, I haven't looked at her X-ray in a couple days, but we just got the MRI report back, and they said nothing.
And
No
she didn't have any recent trauma.
She did. She fell. She like missed a step and fell flat on her front. And
all
she's
right,
not
well,
able to like, lay down or anything.
yeah, it's on T11. You said, but there wasn't any compression of the end plates. The vertebra is basically square.
It looks pretty square. She's a little bit older, so there's a little bit less to it.
That's kind of that transition area. Do you recall if there's an open space at the posterior at T11-12 or 10-11?
I don't think very open.
Okay. Yeah, I always follow my instrument. Something like that. We say if there's an end plate fracture where the superior end plate is fractured in the thoracic area, we adjust the bone above the fractured bone. But if it's the inferior end plate, then we adjust that bone. In this case, there's no end plate damage. There's just the white line that you think is a fracture. So there, you just have to follow your instrument as to which one to adjust.
Okay.
Put her prone, lock the thoracic piece, or only let it drop just a little bit if she's uncomfortable. And then just use a thumb thenar contact on it, and it should move really easily.
Okay. Thanks, Doc.
Yep.
Hi, can you hear me?
Nico, do you have a question?
When you have a patient with progress in the first few visits and they hit a plateau, what's going to be your approach with that?
Yeah, we'll see that a lot. So this may indicate that you might need to move up one bone if we're in the spine. move up one bone higher. Of course, you have to check with our instrument, make sure that it's ready to be worked on. A lot of times, because the subluxation exists, the vertebra above will misalign, and sometimes they, as we correct the initial vertebra, the secondary problems will start to show up, and usually show up above the initial one. So a lot of times we'll end up moving up one bone or two bones higher, depending on what the instrument indicates. So that's the most common finding with that is just, continuing to follow up with the improvement and the analysis and make sure you're following the problem up. We've adjusted, sometimes we moved up 4 or 5 bones consistently, one above the next on some patients. So if you reach a plateau, then the question is, do we still need to work on the same one, or when we reevaluate, are we finding with our instrument and our motion, our palpation for pitting edema and so forth, is that indicating that we should move upward?
Thank you.
Yep.
Do you want me to show the website now?
Yeah, go ahead. Before we lose everybody here, I want to thank you for joining in. Enjoyed getting together with everybody and presenting on the shoulder. But I've had a lot of questions asked about the change in the seminars that we're doing. We're now calling them the Gunstead Revolution. Basically, we're still at the live seminars. We're still doing the same things. It's just more concentrated effort on doing the technique and the concept application. So we work a lot on instrumentation and palpation, a lot on our evaluation steps, our analysis steps, and then a lot on the technique. I mentioned to another group that when we did our first seminar with the new program, there was one person that was in the lower quarter, and I seldom ever have this thought go through my head, but I thought, man, how is this person ever going to be able to adjust with the Gunstead method? There was just such a lack of confidence and inability to get into a position, and I mean, I was almost to a point where I was going to say, hey, do you want your money back? But by the time she finished the third live seminar, she was right up there with everybody else, able to do the setups. She passed both the X-ray and the technique tests, and looked very confident in what she was doing. So the reason I say that is because the live seminars are a very concentrated effort to be more specific on understanding and learn and applying the concepts that Dr. Gunstead taught on motion palpation, on static palpation, on visualization, on the X-ray interpretation, and the instrumentation. Those are so important to our analysis. And so we decided to focus primarily on those concepts, teaching and practicing over and over again the concepts and the technique during the live seminars, and putting the modules, the information on the modules that I typically call the classroom work, put that onto the modules so that you could look at them on video and at your own leisure, between classes or in the evening after classes and that kind of thing. So that material took up, probably 20, 25 hours of time, just what we call classroom work. And so now a lot of that can be handled on the videos by studying that information on those modules. So, you know, we just felt there was Dr. Jerry and I for 3 years had talked about trying to figure out a way to keep more students and young doctors in the Gunstead program. Not just our program, but in the Gunstead work. Because we found that so many students, as they got into clinic or graduated and got into their own practices, were falling away from the Gunstead work. And so we just couldn't figure out some of these, well, I shouldn't say some, a lot of these students and doctors were solid Gunstead people while they were in school. And later to find out that they'd completely gone away from the Gunstead system. And so we tried to evaluate why that would happen. And so we came up with 2 problems that we felt needed to be solved. The first problem was standardization of the technique. And for just a second here, if you would, everybody unmute your mic. I want to ask you a question. So everybody take your mute off. Right? I want to ask this question. How many of you have gone to a Gunstead seminar? Whether it's, you know, one of the big name seminars or whether it's a workshop that a doctor from another state flew in to teach or a doctor locally taught it. How many of you have been to some kind of Gunstead seminar? Just say yes.
I have.
Yeah.
I have.
Yep.
Yes.
Okay. Quite a few, huh? All right. And so the next question is, how many of you were taught conflicting methods to adjust the same area of the spine? Let's say for the neck. How many of you have been taught more than one way of adjusting the neck by different doctors?
Yeah.
Yes.
Just say yes.
Yep.
Yes.
All right. So exactly. This is a problem that we've run into. You know, somebody labeled us first generation Gunstead doctors, meaning you know, the first generation of doctors that were still able to learn from Dr. Gunstead himself. But just in this first generation, since Dr. Gunstead's death in 1978, there's been, as I look around at different seminars, watch different doctors adjust, there's multiple ways that people are doing their adjustments that are not the way Dr. Gunstead taught it. And so the standardization that Gunstead taught of his own technique has been eroded a fair amount. Now, you know, I think just any Gunstead adjustment is better than most other technique adjustments. And I don't mean to offend anybody, but I truly believe that. It's not just because I'm a purist. It's because I know that if a vertebra is subluxated in 3 different directions, why on earth would I use a technique that only corrects one of those? Okay, when I know I have a Gunstead method that's going to allow me to correct the vertebra in all 3 of its aspects of misalignment. So, we all agree that the Gunstead technique is a difficult technique to learn, right? Okay, it's not easy. It takes a long time to synchronize all of those steps that we learn in our setups to get our first adjustment. So, we need to capitalize on that. We need to own it. We need to own the fact that we can learn the Gonstead method by studying the concepts and practicing the technique in such a way that will be consistent each time you attend a seminar, and that you'll get the same instruction over and over again to reinforce what you learned at the previous seminars and online on the modules, and make sure that you are applying the technique in a manner that we feel that Dr. Gonstead taught us when we had him at his live seminars. So the solution to that first problem is trying to standardize the technique and get everybody doing it as close to the same as possible. And then that leads us to our second problem that we had discovered, which really is almost consistent with the first, is the lack of ongoing opportunities to have information available when you need it to be able to take care of your patients, whether you're in clinic at school or whether you're a young doctor who just out graduated and starting your practice. We just felt that there was a big void there where students and doctors at this prime time of the learning experience don't have enough information to consistently answer the problems to patient cases that come in your door. So the solution for this second problem is to try to provide ongoing information so that you have the answers that you need and have somebody to talk to when you have a problem come up, whether you're in clinic at school still or whether you're in your own practice. So we've come up with some ways that we can do that, and some of it, of course, is online, and that's what makes the Gonstead Revolution seminar series a little bit different than my boot camp seminars. I'm getting older. I'm not going to be able to do this for a lot of years longer. Most of the other guys that used to teach with me or I taught with, they're gone, and Dr. Gonstead's gone, and so we need to make sure that we're passing along information that's as close to the source as we can get. And so the benefits of being in the Gonstead Revolution program is about 6 or 7 fold. The first thing is that you get immediate access to the module. The module has videos on it. The first one has videos on instrumentation, motion palpation, technique, X-ray analysis, some discussion on it of other topics. And so you study that material because at the Friday of the first live seminar, a month later, after you receive the modules, we have our first live seminar, and you'll be tested on that material. You have to pass the tests, but with at least a 75% grade in order to be qualified to pass the certification test. Okay, so that's number one, immediate access to the modules with all that information. You also get immediate access to the VIP page, Facebook page, where only people who are in the program have access to. And on that, we monitor that pretty much daily. If there are questions that you want to submit or a video you want us to look at your technique, to critique it, we will do that for you anytime that information or question is submitted or a video is submitted. Most of the time it'll be me answering questions. Sometimes Dr. Jerry will jump in there and answer some questions as well. Maybe Dr. Luke will get in there and answer questions as well. But that's an opportunity there for 24/7 really, or 16 out of 24 or whatever, that you can ask questions and get help on any problems that you might have come up. And that's not just on chiropractic. If you're having a business problem and you're new in practice and you're wondering how to solve a business problem, we can try to help you with that as well. Another Facebook page that we have is more of a general page for anybody that wants to get on. This is the students' tips. The student tips Facebook page. So anybody can get on that, but we don't allow doctors on that site. If there's any on there, they've slipped in somehow. But it's just for students. So you can ask any question. Your skill levels are all over the place. Some know a lot about the technique, others don't know much at all. But we want you to feel safe in asking any question, no matter how basic it might seem to be to you, without any negative responses. So those are two of the Facebook pages that we have. Let me look here. Then twice a month, we have, again, only for those in the program, we have a hour and a half Zoom meeting where, again, we can submit questions and videos. But to start off with, I usually do a presentation on something like we did tonight. I'll talk for however long, 10 minutes or up to 30 minutes or so on a topic, and then there'll be Q&A and videos and things like that we can review and help you with any problem cases that you may have. Then, of course, we have the 3 live seminars. So you have a module 1, live seminar 1, module 2, live seminar 2, module 3, live seminar 3. And at each module, you'll get different information. And at each live seminar following that, you'll have a concentrated effort to learn and practice one-on-one the whole seminar weekend on those topics that were on the module. We'll also have periodic webinars, such as this one, where we'll get on and talk about different aspects of the technique or concepts, where people can join us from around the country. And then finally, we have 2 certifications that we're doing. One is going to be on X-ray. Anybody, no matter what level of school or graduated doctor of chiropractic, can get the X-ray certification. You have to pass the test, though, on X-ray analysis. And it's not easy, but it's fair. For the second certification on technique, you have to be in clinic or a graduated doctor in order to be qualified to take that certification. So those are the reasons why we have started the seminar, the Gunstead Revolution seminars, and that's basically how it's run, how it's set up. So we're kind of replacing. You don't have as many hours. You don't have 100 hours, but you have pretty close to it. We have about 86 hours of actual in-person or online instruction with the live seminars, the Zoom meetings where we meet. There'll be 18 hours of time together on the Zoom meetings, and 6 hours, I think a little bit more than 6 hours on video where we're teaching from the video on the modules. So the rest of that time is kind of taken up with, we had to hire a couple staff in order to manage the Facebook stuff and the online stuff that I don't have any idea how to do. So that's how the program's set up, and that's how it's run. And boy, I'd sure like to see a lot of people get signed up on it. You can go to the Facebook page or the online page at gunsteadrevolution.com if you'd like to get signed up. And we're starting pretty soon, either in January or February, this month or next. So you want to get signed up on the different locations. Anybody have any questions that I haven't answered? Okay, thanks for taking your time. I appreciate it. Look forward to being with you again sometime in the future.
Thank you for doing this tonight, Dr. Wood. We really
Yeah.
appreciate it.
Thanks for organizing it there.
Yes, sir.
Thank
As many people that want to sign up, there are locations that are on the website as well that he's going to. And it's an incredible opportunity to, again, keep raising what we do. So thank you again for everything, Dr. Wood. We really appreciate your time tonight.
You betcha. My pleasure.
Yeah, thank you for organizing and thank you for your time.
Thank you.
Thanks, Doc. Good to see you again.
You bet, Anthony.